So I see that folks are logging in still, but I'm keeping an eye on the clock, and I think maybe we'll go ahead and start with our introductions as folks continue to join us, because I want to make sure we take advantage of every minute of this hour. So welcome everyone to our Population Health Spotlight. I'm Dr. Esther Chernak and have helped to coordinate this series that this year is devoted to infectious disease related topics. And the series this year is sponsored by the Dr. Eli Abertin Lectureship Fund. Dr. Abertin was an internationally renowned infectious disease physician. He was a faculty member long associated with the Medical College of Pennsylvania, which eventually became the Drexel University College of Medicine. At the MCP and at Drexel, he served in a variety of roles. He was vice chairman and then chair of infectious diseases and the Department of Medicine. And at the time of his death in 2007, he was an associate dean for faculty affairs at the Drexel University College of Medicine. And he was a long-standing mentor and expert in infectious diseases. And so we're just using this series to honor him. So welcome again. Today, our speaker is Dr. Heidi Larson from the Vaccine Confidence Project and the London School of Hygiene and Tropical Medicine. And I'm going to ask my colleague in environmental health, Professor Tom Hippert, to introduce Dr. Larson, and then we'll go into her talk. And I will just remind folks, if you have a question, and hopefully there'll be lots of time at the end for questions, there's a Q&A button in your Zoom screen, and please use that to post questions, which we'll use to pose to Dr. Larson. So, Tom?
Great, thanks, Esther. Yeah, if I do say so myself, I think this Population Spotlight series has been pretty fantastic so far, and we are really delighted to continue that trend today with Dr. Heidi Larson. As Esther mentioned, Heidi's a professor of anthropology, risk and decision science, and the director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She's also a clinical professor at the Institute for Health Metrics and Evaluations at the University of Washington, Seattle, and a visiting professor at the University of Antwerp in Belgium. In 2021, she launched the Global Listening Project, which she's going to speak with us about today, and conducted a 70-country study of public experiences and trust ecosystems during the COVID-19 pandemic. She's also currently leading the Lancet London School Commission on Emotional Determinants of Health. She's formally headed the strategy and communications around new vaccine introduction for UNICEF's Global Immunization Program and served on WHO SAGE Working Group on Vaccine Hesitancy. She's also the author of Stuck, I'm Nothing If Not a Prepared Host, How Vaccine Rumors Start and Why They Don't Go Away. Fantastic read if you haven't checked it out yet. And brace yourself, as I think I saved the coolest note in this impressive bio for the end. In 2021, Heidi was named by BBC as one of the 100 most influential women in the world and was awarded the 2021 Edinburgh Award for Science. I won't even attempt to top that last one, but I'm also delighted to say that Heidi is also my DRPH supervisor at the London School. So I will turn it over. We're really happy to have you talk with us today about this timely and important issue. I'll turn it over to you, Heidi.
Thanks so much, both Tom and Esther. I'm going to leap into sharing the slides here. Let's see. Share. Okay. Sorry, it decided to land right in the middle of what I'm going to show you. Okay, I'm going to talk about, I came up with this title, Emotions, Inequalities, and Technologies, Why They Matter to Infectious Disease Prevention. I got lucky and got a MacArthur Award in 2021. And well, actually, yeah, 2020, actually. And it was to expand the scope of what we were doing with the Vaccine Confidence Project to look at the broader issues around confidence and cooperation during COVID. And then some additional funders came in so we were able to expand to 70 countries. I really thought that this is a once in a century pandemic we were in. The last one was in 1918. That was this scale. And if we really needed to understand the experience of people on the ground if we were going to be able to prepare better for the next one. But I didn't want to sit in London or Brussels or Washington or whatever and come up with a questionnaire, a survey to roll out. I really wanted it to be informed by some formative research, and we did in 6 cities, 6 major metropolitan areas in different regions with different epidemic experiences. We did 6 focus groups in each of them, 10 in-depth interviews in each of them, really to hear just in an open-ended way what people went through, what were their issues, how did they rate the government, a number of things. And from all that, we picked themes that came up across all of those settings. And because some of the things they talked about were very specifically local, but there were quite a few issues that came up again and again. So that's what informed what we then rolled out in a 70-country study. This was the sampling. They were all nationally representative samples. These were some of our interviewers. We did a mix of telephone, internet, and face-to-face, house-to-house interviews. All were in local language, and it really depended on the, whether they had telephone or internet saturation, or whether, in certain countries that we were in, we really needed to be doing face-to-face. In this initial focus group period, I just wanted to show you, I'm not going to go through all these boxes, but out of all these open-ended questions and discussions, we asked, what was your top concern at the peak of the epidemic in your setting, of the outbreak in your setting? And in Abuja, the thing that just kept coming up was food security, food security. That was our biggest anxiety and challenge. In Delhi, there was very abrupt and hard lockdown. It's very much a cash economy, and people were worried about, losing the cash flow, and were they going to be able to put food on the table. New York, everyone was talking about mental health. That was their biggest mental health. In Paris, they talked about loneliness. They talked about the frustration of a lot of domestic stresses and tasks. Sao Paulo, interesting, talked about all kinds of domestic stresses, relationships breaking up, divorces, just from the whole pressure of the situation. And in Bangkok, they talked about a lack of socializing and particular concern about young people and their isolation. Now, this was the things they raised as their top worries or anxieties. Now, when I looked across this and I thought, it's so interesting. Some of them are slightly related, but really different issues that came to the top. But nobody said their biggest concern was COVID. And I think this is a major message for policymakers and for others who were very focused on flattening the curve, jabs in arms, very much monitoring cases and case count and death count. That's not what people were more concerned about. And that needs to be, I think, more evident in how things were. It was always the scientists and the political spokesperson. We never saw someone up there with the Minister of Health or with employers or with other aspects of their life. And that's what they felt that was really missing. To move forward with this in terms of we wanted a framework to assess, moving ahead for societal preparedness. We thought, we should look at the individual, the society, the system. We looked at information sources, support. Who did people turn to, and future outlook. And then we found 3 buckets of key things that mattered for what we thought for moving forward: societal preparedness, willingness to cooperate at a system level. Okay, people are willing to cooperate, but do they have the capacity to organize at a societal level? And what are the individual's sense ability to cope? I have to say, in the 70 countries we asked at one point, if we are faced with another crisis in the next coming years, what would be do you think you could individually have the ability to cope? Do you think society could pull it together? Do you think your government is ready, can handle another one? And do you think your leadership is in place? Pretty much globally, the numbers that came out on top were individuals' sense of they could cope. Then it was like, and society could probably hold it together. But really, when it came to what they perceived as government's ability to handle another crisis and leadership being in place, the numbers really went down. But I think, to me, the message is we really need to leverage more and respect and engage people more, because they feel like they were left out. They didn't have a voice, but they had an ability to cope. They could have contributed if they had been given some kind of role. So we did a lot of asking about trust from different angles. And in this case, we are asking, do you trust your government to act in your best interest in a time of crisis? And the numbers were very varied. You can see the US is kind of right in the middle there next to the median, but it was highly varied. This kind of picks up also on my earlier point. If we're just looking at the G7 countries, this is the scoring, so to speak, that people, the percentages of people who felt like their country's government handled the pandemic well. Japan was the lowest, only 12% thought they handled it well. The numbers went up a little bit. They were all relatively low. The US looked the highest, but actually I think the critical indicator is that it was 50%. It just reflects that the other 50% didn't. I mean, it was very polarized. But when you look at, I pulled out all the case count and death count in these countries, and actually Japan did the best, but the perception was they had some of the lowest. I've been spending the last year going around to a number of countries, sharing this data, getting feedback, trying to kind of probe, why was this score so low? What was the issue? In Japan, I heard people said, well, it wasn't because of the government that our cases were low and our death count was low. That was because of us. That was because of the people. We knew we had to wear our masks. We knew we needed to get vaccinated. We've had these things happen to us before. We knew we should stay inside. And then they also said what we rated the response was about how they took care of us, our livelihoods, our education, and our well-being, not case count and death count. We looked also a lot at gender differences and in the ability to cope in a future crisis. Generally, women reported lower levels of being able to cope, probably because they ended up with more that they had to do between their own work and childcare and other things. Except for Liberia, they seemed, I don't know if it's a more matriarchal society or what, but it did well. This one really shocked me, and maybe it shouldn't have. But by the way, I should say that this data was all collected, but August, September of 2023. So the official emergency was over, so to speak. I mean, the pandemic, as it were, but we still clearly have COVID. Anyway, just so you know when this data was collected. So when we ask, do you feel that your voice is being heard and listened to by political leaders. Men under 35, 90%, 9 out of 10 young men in the US felt that they were listened to by political leaders. Men over 35, it was already quite a bit less. Women under 35, less. But women 35 and older in the United States, only 3 in 10, 30%, felt like they were being listened to by political leaders. That's pretty dramatic. We looked also, I really try to encourage more ecosystem approach to understanding trust. We often see studies about trust in scientists or trust in health professionals or trust in religious leaders singularly, but we don't put it in the context of who else people are turning to and trusting. Because we've really seen that, you can trust your scientist, but then you're going to go to a few other people and get their influence, and then you make up your mind. We hear also disaggregated by age, and you can see that again, men under 35 were reporting the highest trust levels across a lot of different categories here. And the question was, imagine there was another major crisis, flood, pandemic, food, water shortage. We were kind of crisis agnostic, not just pandemics. And what did people trust which groups to act in their best interest? Like whether your employer, do you trust your employer? Do you trust your neighbors? And again, women over 35 tended to be the lower ones, not everywhere, but lower. This is just, this isn't all the 70 countries, but just to show you the point I was making earlier, you can look only at the scientists and think that, well, it's reasonably high, not everywhere, in terms of trust in scientists, but then you can see in Ghana was, of all the African countries, had the highest confidence in science, trust in scientists, but they also had 78% in religious leaders and community leaders, and 85% in the family doctor. In the US, only 69% had trust in scientists, and followed by community leaders, but family doctor and family was 78% compared to scientists at 69. So just, it shows you and in Sierra Leone, for instance, 74% trust the scientists, which seems relatively high, but then 87% trust their religious leaders. And 83% their own family. So, and they don't just go to one or the other, they go to multiple, and that all weighs into a picture. So we need to keep that ecosystem in perspective. This was also, to me, a very concerning finding. I've been working a lot on emotions, and as Tom mentioned, I'm leading a Lancet Commission on the emotional determinants of health, not just pandemic, but this was one piece of what we were thinking about. Anger by the publics, and actually this is 41,000. There's an extra zero missing at the end here, but because not all countries wanted to measure emotion. Anger went up in the second year, probably frustration that it kept going, and then it went down. Fear, this is at the start of the pandemic, in the middle of the pandemic, and now being September 2023. Fear went down, anxiety went down over those periods. Sadness kind of wobbled along at the same. Happiness went up, but it was pretty low all along. Hope was high-ish. I mean, compared to other things, still only 22% for the first, beginning and then in the middle. But then when it was effectively over, and I think the hope was we're going to get out of this and get back to what we were, hope went down at the end of the pandemic, because I think at that point people realized we're not going to bounce back. It's not going back to what it was. And it was pretty striking. And actually the most worrying thing is we saw that indifference went up and up and up and was very high. I mean, really went up at the end, which I honestly think that this hardening of people's sentiment has contributed to polarization and frankly, some of the conflicts we're seeing. We have already in our vaccine confidence work over the years, and again here, see how strongly correlated vaccine sentiments are with trust in government and trust in institutions. And the vaccine hesitant is the green bar. The ones who were higher levels of vaccine hesitancy also had higher levels of feeling that these institutions were a dividing force, where it was the opposite for the confident. One of my other big concerns out of this research is about 18 to 24-year-olds. They really struggled and really felt like they paid the price for what was largely an older person's disease. They compromised their social life, their education, some were starting jobs. And they're not going to get those years back. And there's actually quite a bit of frustration, and we saw spikes in youth suicides in a number of countries. And this is just, and we launched a report on this at the UN General Assembly in September 20, this past year. It's on our website, the full report. And there's also the panel session, which is quite interesting, is on there. We did deeper dives too in places where we saw there were issues. And in this case, we did a deeper dive with like 5,000 people in New York, Atlanta, and Tokyo. And we compared, because we saw a lot of anxiety and depression overall, looking at, again, gender differences and also the differences between these cities. And then we looked at age-related trends in these different cities, which was very interesting because, again, the highest levels of anxiety and depression were the 18 to 24-year-olds, even up to 34. It went down over each decade, but then started to increase again for over 75. And curiously, depression really went up over 75 in New York, whereas in Atlanta, anxiety went up. And these are the kind of things with this data we go back and try to understand, because I think very strongly that if we don't address and deal with some of these issues, I think a lot of people want to put the pandemic behind them. But I think we shouldn't be thinking about preparedness for a future pandemic. We need to focus on COVID recovery now. There are a lot of issues in the public that are residual issues. We still have kind of a chronic and worsening vaccine hesitancy, and some of it, and in different types of mental health issues and other issues that have come up. One of the things that happened during COVID was we threw a lot of technology at people, aside from, I mean, we forget now that we wouldn't be having a lecture like this before COVID. People weren't, I mean, you could do video conferencing, but the level of remote working, schooling, all of that, and many families, in terms of inequities, didn't have a laptop for every kid in the house, and mom and dad, if they could work, even if maybe they couldn't work remotely in their jobs. And then technology for vaccine certificates, making appointments, and a lot of that. So we were looking at, and in some settings, like in India, the first app they developed for your vaccine certificates only worked on certain phones. And if you couldn't afford that phone, you couldn't get the app. And I mean, they eventually sorted that out, but there were issues like that came up. A lot of anxiety about people being tracked, being controlled, being a lot of things. But also the other big issue that came up is willingness to share personal data. And we did a sub-study with 11 of these countries on willingness to share data, and anonymized genetic information, anonymized results from diagnostics and medical records, asking about, would you be comfortable or uncomfortable with sharing? If it were developing a treatment for myself, which they were more willing, contribute to wider research, or contributing for wider research for a condition I do not suffer from. So it was actually pretty interesting here. There was thankfully a higher level of willingness, but still people uncomfortable. We then looked at a lot of different types of location and movement tracking. That was interesting, facial recognition. And we looked at who they would be willing to share with. And the highest level of willingness to share was with healthcare professionals and research institutes, but the numbers really went down when it came to the healthcare system, government, and particularly business. Government and business were very low in terms of their that they were least willing to share with government and business. mRNA, among the multiple new and different science aspects of science and technology, we not only had a brand new virus and a lot of new vaccines, we had new ways of making vaccines, and it all was a lot of newness, and people, rumors, anxieties, all are more hyper accelerated in these times of uncertainty and unfamiliarity. This is about willingness to share, to accept mRNA vaccines. We're doing a lot more on willingness to accept vaccines and technologies and therapeutics made with mRNA. Japan is a growing movement among nurses against the mRNA, particularly the self-amplifying, but it varies by country. The US had the highest amount, still 53% of definitely yes, but the others were really quite low. We also looked across different race and ethnicity, because that's another aspect where in terms of inequities and access, what was really encouraging here is even though the Black and Hispanic groups had heard a great deal or a fair amount about mRNA, I mean, they didn't hear as much as the white and other groups, but their interest level was quite high in learning more. So the appetite was there, and that's a gap that should be addressed. Because we had so much pre-COVID data on vaccine confidence, my group launched a vaccine confidence index in 2015. I founded the group in 2010. So we already had a lot of background confidence data. And for the 55 countries where we had pre-COVID and then post-COVID vaccine confidence data, we saw that 53 out of 55 countries had a not insignificant drop in confidence. This was published in the UNICEF 2023 State of the World Children's Report. That press release you saw about in the beginning was their press release for that report. This is just the countries that had more than a 10% drop in confidence, and it was really quite serious in South Korea. And I actually have a South Korean researcher with me, and we're working with the Ministry of Health in really looking at this and thinking about strategies to rebuild confidence. As I mentioned earlier, this younger group was under 35, really was quite frustrated and resentful of a number of the things that they had to go through during the pandemic. And we saw really the drops in vaccine confidence were largely driven by the under 35 group. We explored reasons for refusal to accept a COVID vaccine. This was in a collaborative study we did with the World Health Organization Asia region. And what was fascinating is that the red bar, which is concern about side effects, were the top concerns in Vietnam, Laos, Philippines, Myanmar, Japan, Korea. But then in some of the other countries, it wasn't about side effects. They just didn't trust the vaccine, or there was a lack of knowledge, but for different. So it's really important to recognize that every country is different, and the angles and the issues. We actually had spent 5 years doing a lot of trust building and engagement around Ebola vaccine trials in Sierra Leone, DRC, Rwanda, and Uganda. And a lot of what we learned, especially in the context of doing research in the time of an outbreak, were very helpful for us in some of our COVID work. And this is all available online in our Vaccine Confidence Project website. I think just my last few slides here are about some of the innovations and ways, the things that we had to reach whole different populations than we do in routine vaccination. And also what it did was kind of stimulate some creative kind of engagement that we don't do typically with routine. And I think one of the best things I've seen in the US is the Black Doctors Against COVID initiative. And they really, really decreased the hesitancy and increased the confidence in Black and Latino communities to accept vaccines. I mean, I think this one, when community comes together, it really, and as one woman said to me, I'll believe this thing when someone who looks like me and talks like me tells me it's the thing to do. And really, I think that was a real theme. Another thing that, like, this was the example of Bhutan. All these vaccines arrived. They went through their regulatory, safety, everything, but then they were blessed. So they were bringing together the science, but also the values. And I think we often miss on that value aspect. I saw a similar thing in Indonesia. They had a pretty rough experience with an MR campaign in 2018, measles rubella. A few imams started to really create a campaign against it. And when it came to COVID, having been through that, the ministry, talked about the safety and regulatory approval, but then brought in the Organization of Islamic Leaders. So again, bringing together the values as well as the science. This was from polio, but these were some of the examples of just engaging people, giving them an opportunity to be involved. And they could do similar things in COVID. Just the patient experience, again, is so important. If somebody is sitting on a cold chair feeling not respected, versus feeling like there's some engagement and sensitivity there, it makes a difference. And my last slide is my favorite vaccination campaign in Bolivia, called it Doses of Hope. And I think we need that positive signal. And over to questions. Sorry, I kind of ran through there, but I really wanted to leave time for discussion.
Great. Well, thanks so much, Heidi. And just a reminder to folks, if you have questions for Heidi, please feel free to add those to the Q&A, and we'll do our best to get through as many of those as possible. While we're giving folks a chance to dive in there a bit, maybe I'll just I'll start with kind of a big picture question. Heidi, we've got a pretty large group here, and it's a nice blend of students, staff, and faculty, folks who are, I think, broadly interested in this growing concern around trust in science and vaccines and public health. And we've got a blend of researchers and practitioners. And I was just wondering if you could speak to either of those folks now in terms of, if you're someone who is interested in working in this space and tackling this really difficult challenge and you want to make a contribution, do you have thoughts for the researcher or the practitioner about, what's most needed and where we should start and hope to make an impact in that?
This is a question coming to me.
No, this one's coming right from me while we wait for some more
Okay.
questions to come in.
Well, I think the important thing is we need to understand where the issues are, and our research, I really think that our research needs to be more responsive to what the issue is, rather than driven by what not. I mean, obviously, some research will be driven by our scientific curiosity and our wanting to, demonstrate effectiveness and efficacy and the value of certain things and trying out novel approaches. But I don't think we do enough research that really is responsive to where there are issues. Like in the 70 country study, there were a number of things that came up that really, I mean, I felt like what we did was pick up issues that needed more attention. And what you might want to do in one country probably is going to be different than what you would want to do in another. But be issue driven.
Right.
I'm going to go ahead and ask a question that's in the Q&A box. Please, again, feel free to add questions to using that mechanism. So someone asks, in the US, what emerging challenges do you foresee regarding vaccine hesitancy and public trust in science at both governmental and patient levels? And then there's a follow-up question, which is how can scientists combat misinformation and promote empirical evidence to address the root causes of vaccine hesitancy and public understanding of vaccines and disease, especially at the current moment when it's not a federal priority?
Well, one, we got to get creative with language. I think that pulling the lens back differently and not using language that is going to flag attention to, I had already been wanting to, I never thought I would stick with vaccines for so long. I had been working a lot in AIDS and sexual reproductive health, and then HIV, TB. And when I was asked to come back to UNICEF to launch Gavi and work on vaccines, I thought it was going to be pretty boring, to be honest, but interesting. I never thought it would turn out to be what it is, but yeah, how can I answer that question? Can you ask it again?
There's two questions, and they're both, I think, big ones. One is just what emerging challenges do you foresee regarding vaccine hesitancy and public trust in science in the US?
So I think the important thing right now is that we figure out ways to continue our work. I think we have to pull back from some topics, but think about how we can frame them differently. I was already going in that direction before COVID, because I realized through the vaccine work that I think only 60, I would say in general, about 60% of the time where we had issues, it was maybe about the vaccine, but a lot of times it was about other things. And I think trust in government, trust in institutions, trust is a big issue. Decision-making, communication strategies. I think we can look at more proactive, positive things. I think sometimes you have to also embed your research in what is acceptable at the time, to be very frank. I mean, nutrition, well-being is, listen to the environment and where the interest is. And there are ways that you can embed and do your work that will contribute to thinking. Not everything, but I think we're going through a time where there will be, historically, there have been various waves where there have been challenges in terms of what you can and cannot do and what you can and cannot say. And sadly, we're in another one. But there are ways to do things. I'll never forget when I was in Nepal, the government said they didn't want any news or other things on the radio, only entertainment. So, and it should only be for that. The only news that should come out is from, the president, prime minister's office or whatever. So what did they do? They started to sing the news. They started to do entertainment that wove in some of the topics that they wanted to get through. And I thought it was it's a small example. It's quite different in the sense, but it is, I think in a way, these kind of situations force us to be more creative about our work. And maybe, out of that, we might bring new perspectives that we wouldn't have if we had been continuing to do what we're doing. It's not that I'm supporting the current environment, it's just trying to be productive.
Understood.
In a difficult time.
There are a couple of questions in the chat around some of the data analysis and collection, but sort of the methodology. So one of the questions is, in the surveys, how were individuals chosen so that there was minimal bias? Did you have individuals from both cities and rural areas answer questions? There's a similar question around were analyses affected by political affiliations, if you looked at that?
All of the surveys, it was all nationally representative sampling. We worked with research groups that, because we already had 10, 15 years of developing a global research network and running our vaccine confidence index, the way we could do this in the time that we did it was we leveraged that whole network and research network we had established and just expanded the scope of what we were asking. And, over that time, we had a really robust approach to nationally representative samples. And in some cases where we saw issues, like in those last slides, some of the last slides I showed you in the city, we've done deeper dives in cities, or in UNICEF, for instance, has asked us to go back and do a deeper dive, more nuanced state level look at Cameroon, Kenya, and Philippines, for instance, and other countries have come and asked us to do kind of more localized looks. So think of it as a triage system, or cascade.
Got another question. What strategies do you find working to counter misinformation? How do they differ from more general approaches to educating about and promoting vaccines more generally?
I think we have to, I think there's been maybe an over focus on fact checking and trying to change. Of course, we want people to have the right facts. I don't mean that, but it's a pretty narrow look. We have a bigger issue going on right now, which is really tsunamis of a lot of, and if we were fact checking one at a time, we're not going to catch up with this. We do, of course, need any kind of, when we do see issues emerging that are clearly wrong, drink a quart of chlorine and that'll cure you. Absolutely need to get different stories out there that make it clear that that's not the case. And where we do see things that are potentially harmful, of course, we need to get out correct information. I would not ever respond to pieces of misinformation online. It just amplifies it. what you need to do is, I call it kind of inoculation. You need to surround it with better, more evidence-based, accurate stories. But we also need to look at what I call the fertile ground factor. We really need to, and there are a couple countries doing very creative stuff. Finland is among better ones in schools already. Get critical thinking, get different kinds of classes where you can, in schools, get kids and others to be thinking about what are the things that should signal that this might not be right, or ways of fact checking. But there is a much bigger area that worries me that is less tangible, but is very potentially harmful. And that is the groups that are purposefully spreading it. There's accidentally spread misinformation where people think something's plausible and share it, not knowing that they're spreading something that's not accurate. But then there's purposefully spread disinformation for political, financial, or profit reasons, or whatever. They are very sophisticated and very conscious of where the regulations and where the restrictions are, and have found all kinds of ways to go around it. And one of the main ones is emotional manipulation, basically doing types of communication online through different kinds of stories and other kinds of manipulated ways that is not misinformation. You can't take it down. I mean, I've seen things like, do you really know what's in a vaccine? That's not misinformation, but it begs you, it prompts you to question. And there's other kinds that have been far more damaging, bullying and cyberbullying and what goes on. And particularly it was pretty bad when these younger ages were isolated and spending much more time on social media. And there's a lot of this emotional manipulation. I think we have to be very alert to that kind of thing, and really paying attention to it, and work to get we're not in the spaces where people are in public health. We are in the dark ages compared to where most of the public is, and we need to really we're not going to get ahead of it, but catch up with it.
Great, thanks. So we've got two related questions on just the overall polarization that we're seeing right now. So one question was just in regard to the data collection and analysis you've done. To what extent were the analyses affected by political affiliation? Was that something that you looked at as well? And did you see any trends come out of that as a driving factor?
We didn't do, because we were in so many different countries and a lot of them had different political dynamics. We didn't in the global survey probe that, but we have done some, and also with some of our collaborators who took our data and then again disaggregated it against political characteristics. There's clearly political influence, and also we've seen in our Global Vaccine Confidence Index running, we do the 4 key domains of our Vaccine Confidence Index are perceived importance of vaccines, confidence in the safety, in the effectiveness of the vaccine, and compatibility with religious or other beliefs. And one thing that we really discovered, and maybe should have figured out, but anyway, we've got data behind it now, that the same religious group could be reporting quite differently in different countries. So it wasn't about the religion. It was about their, if they were a majority in a country, they might have a very positive view about a vaccine. And that same religious group, if it were a minority that was also potentially a discriminated minority, they would have a much lower confidence. So a lot of religious and other things are politically embedded. And I think we really, scientifically, we tend to pick out specific things we need to look into, but these are like, think of the microbiome. I mean, we need to think in societally wise that, you know, political environment, I mean, Brazil and the US in particular, you know, and there were some African countries where you had political leadership that was taking people away from science. But the people who, I mean, I'm just working on an article now with a colleague that's like, not all trust is good. Trust in itself is not necessarily a good thing. It depends on who and what you put your trust in. You could put your trust in all the things that are going to actually make you sicker than something else. So,
Great. And so on kind of on a related note, obviously the US this is something we're very much experiencing here. And so one of the questions we had in the chat is, how do we as practitioners help to take the sting out of the deep polarization and politicization that is the new landscape of public health initiatives in the US? Any advice for those of us over here fretting about this major issue?
you know, there's no, I don't have any magic wand, but one of the things that I try to do when I'm interacting with very strongly opinions around vaccines, or frankly other kinds of interventions that were important for like COVID prevention or around Ebola, or I mean, I've worked in a number of different outbreak settings, and is to try to find something that, you know, I really strongly believe there's always going to be at least one thing that you can find a common ground, whether it's, you know, kids schooling or gardening or something you eat or what, you know, whatever. Try to find something. I know that in the current environment, that's really hard. I find that one of the big concerns that I have is that a lot of scientists and health professionals, we have data on it, are less willing to speak up about vaccines because they just don't want to deal with the reaction. And frankly, understandably, some of the aggression and violence. I mean, I've had to have police protection at some talks that I've given, and, you know, it's really about vaccines. You know, you think of it as, you know, home cooking and mothers. I mean, it's chicken soup or something. I don't know. It's such a, seemed like such a benign, good thing. And it's just not that way. So I don't know. I think we need to do what we can. One thing is very clear. It's not a time for overt campaigns. I think it's a time for very local engagement in local ways, that is much more ground up, because anything that is, you know, campaign oriented is gonna just, you're making yourself a target in this current environment.
So a question that perhaps is related to this is how to handle the situation when the scientist and the physician give contradictory advice, which I think we experience in this country, certainly during COVID.
That's hard for people who are, it doesn't help people who are trying to make a decision. I think that not all science, I mean, I've seen situations where you got to see what kind of scientists some people are. I mean, I've seen people speak quite boldly about vaccines, and the doctor in front of their name is that they're a doctor of like geology or something. And, you know, they have a PhD in geology or something totally remote from vaccine science. But are, you know, using it to give themselves credentials. So one thing is to understand if it really is a vaccine scientist but, you know, there are debates in science, and the nature of science, and this is what's really hard, is that the nature of science is to doubt and to question and keep investigating. And, it's in science, you never end a paper saying this is the final word and this is the fact. There's always all kinds of, conditions that, until we find a different story. And that's just not comfortable for the public. I mean, for some. So I want to say, get some more opinions, and maybe you can get, if they're too very contrarian, I think you need to throw the net wider and see where you can get more support, and then make your own decision.
Thank you. I think we have time for maybe one or two more questions. There's a question that I want to make sure I understand from Benjamin Gamara. So he writes, I appreciate you telling us about what works for one country and may not work for another country. With that in mind, what would your advice be for research studies where the target population are migrants from different Spanish-speaking countries, in particular focusing on mental health? And he writes, as a background, Spanish-speaking community members may have a stigma against mental health or going to therapy or associated with going to therapy. So any advice for handling or approaching a research study around an issue where there's different degrees of stigma around the topic?
I'm sorry, my battery's about to run out. Give me 1
Sure.
second to get it plugged. Sorry, I thought it had a lot of, so can you repeat the question while I try to plug this?
Sure. And if Benjamin's here and if I'm not capturing the essence of your question correctly, please feel free to add to it. But he asks about doing research studies where you're working with populations where, for example, something like mental health, which has some stigma associated with it, and you're working in communities where there's some stigma about going to therapy, about talking about mental health issues. How do you do research in that area with populations where there might be some stigma? And Benjamin, feel free to add to your question in the chat if you would like to correct my interpretation. Or
I think that is very related to some of the last slides I was showing, where in those kind of situations, you really want to get as many peer or local or work with a mediator from that community, because sometimes people feel like they're stigmatized, and you might have a doctor or somebody come in that actually doesn't have any issues, but because they're kind of anticipating stigma, they might be hesitant to talk about their symptoms or their issues, or not want to talk about. So the more you can have, as my one woman had said to me, people who look and talk like me, that will ease that potential tension, and be there as a kind of, partner with them. So there's someone that they're comfortable with, and that kind of eases that, is what I would suggest.
thank you.
Thanks. Since we're basically at time, just one last question for you. We've talked a lot about the pretty significant challenges we face here, and I think we're all pretty stressed and anxious about that. And I was just wondering if you might leave us with any parting words of reasons to be hopeful that there's progress to be made here. I'm hoping the answer to that is not no, but just maybe thought that would be a nice way to maybe end this discussion today.
Well, I think there's always hope. And we will, if we look historically, we've been through a lot over the years, and things do come back in different ways. It's not going to come back to what it was. But I think we need thinking, intelligent, motivated people more than ever. And I think it's just thinking about ways we can do what we need to do in the environment that we can. It will mean trying to understand where we can work. And that's been very difficult because that landscape is changing by the day. So I would, to the extent that you still have the resources and situation you have, keep doing what you're doing as long as you can do it. And if you lose a grant or a job or a research fellowship, sometimes these things make you think differently about what you really want to do and how you want to do it. And they do test how much you really care about what you're doing. And I think that for those of us who've put our life in this or want to, just keep going. I mean, there's going to be some way that you can do it. And maybe a good time to travel. Maybe a good time to come to Europe. We got other problems here, but there are other parts of the world where you could still do other opportunities, and maybe that's a time to try something else out, find a collaborator somewhere else, and bring that insight home. But to the extent that you can keep going where you are, just hang in there, keep going. Never give up hope. That's for sure.
Thank you so much,
Get
Dr.
that dose of hope. What? Yeah.
Thank you so much, Dr. Larson. I'm keeping an eye on the clock, and I know that you have some time constraints. Thank you so much for joining us and for sharing your really important work with us this afternoon. And thanks to our audience for joining us. And we hope to see you in April, I think April 9th, with Dr. Cindy Plotkin. That'll be our last session of the series. Again, thanks again so much, Dr. Larson, for this really terrific and very thought-provoking hour.
And have a look at either the Vaccine Confidence Project website or global-listening.org, Global Listening Project. And there's a lot of resources on either that might be of interest. Thanks.
Thank you.